20 years ago, I was a postdoc researcher, and I studied the dissemination of lymphoid malignancies in the group of Professor Dr. Stephen Pals, first at the Free University Hospital and later on at the Academic Medical Center in Amsterdam. We succeeded in determining several adhesion molecules which were co-responsible for the development of cancer of lymphoid cells. We and several other groups worldwide worked together in unraveling several molecular pathways causing malignant proliferation. These discoveries formed the basis of better therapies, and nowadays more than 75% of non-Hodgkin lymphoma and leukemia patients survives more than 5 years. Interestingly, we and others discovered at the same time also that some of these pathways and molecular expressions were as much as important in the development of several other non-lymphoid malignancies, like colon cancer as well, although we didn't know the word basket trials at all at that time. Back to the laboratory of the Academic Medical Center in Amsterdam, 20 years ago. One of my former colleagues, Dr. Patricia Kijk, in the research group of Professor Dr. Sigurd Leenstra, studied the terminator of all cancers, glioblastoma multiforme. In the early 90s, no patient survived this devastating tumor for more than 5 years. The average survival was 1.5 years. I thought it was discouraging not to find any clue to tackle this tumor. And secretly, in those days, I considered myself fortunate not to study this dejecting tumor without having reasonable prospects of promising point of action. After all these years in which truly committed researchers and doctors tried hard to change the survival outcomes, unfortunately nearly nothing had changed in the survival rate curves of glioblastoma patients worldwide. This shocking fact my husband Peter and I described September 2040. In 2 weeks' time, Peter developed subsequently tooth and ear ache and in the end also an unbearable headache. MRI elucidated the cause of these pains. Peter was diagnosed on the 3rd of September 2040 with glioblastoma multiforme. It was unreal news for Peter himself, for our 2 sons of 11 and 15 years, and myself, but also for his dedicated doctor. Peter was strong, had never been ill before, didn't smoke, didn't drink, was totally in flow, didn't know stress, was good at sports, and a family man. Peter was 50 years. In the Netherlands, there are 3 brain tumor centers: the Erasmus Medical Center, the Free University Hospital and the Utrecht University Hospital. We decided to go to the University Medical Center Utrecht. And Peter was treated by a multidisciplinary team, including the brain tumor surgeon, a neuro-oncologist, a medical oncologist and a radiotherapist and a nurse specialist, covered by excellent pathology. We trusted this team and their members. Trust is an essential keyword during this life-threatening process. We discussed every treatment option with them, the regular as well as the complementary therapies. And we trusted their experience, their knowledge and their skills. We trusted their international connections. The team was not familiar with a patient and its anticipating caregiver thinking along with them. But we explained that we had to work together in order to do the utmost, and that our patient point of view would powerfully complete their professional perspective. And they did understand the necessity of this co-partnership. They also trusted us. We both developed a high degree of mutual respect for each other's expertise. Although the diagnosis was severe and the 5-year survival not a fictional option, Peter recovered astonishingly well after the operation, in which more than 95% of the tumor could be debulked. We lived with hope in our hearts, but stayed realistic. And so did the team. It felt as if we walked nearby a bloodthirsty dog sleeping, between hope, not to rouse him, and false hope. We also continued to rely. After every crucial decision, we wrote the word vertrouwen in our hands. That means trust. And we accepted that life on Earth is not manufacturable. Despite the best researchers, despite the best doctors and nurses, despite money and the best laboratories, and that no one is to blame. It is simply bad luck, but through it all we learned the meaning of life living to the max in unconditional surrender and love. We did the utmost to live our life with cancer happily, and we decided not to fight cancer, because we think that cancer is not a matter of winning or losing, it's a matter of luck or bad luck. Despite chemotherapy, Peter developed in March 2015 two spinal metastases. These causes a spinal cord injury, and this escalated into an intestinal perforation. Peter became a comorbid and complex patient. We were due to stop every treatment of the tumor. Further therapy was life-threatening, and we decided to watchful waiting. No longer false hope in the outcome of the next generation sequencing and possible inclusion in a phase 1 study. We choose to concentrate on the quality of life instead of the quantity of life. And the team did understand our splitting decision and supported it. Peter came home and I cared for him, supported by home care nurses and our general practitioner. And this time became a precious period in our family life. We were able to say goodbye, we enjoyed the small things of life and the time left for us. We learned that life is love and love is eternally. Peter, my endless love, and the caring father of our two magnificent sons, died 10 months after diagnosis, in the early morning of the 12th of July, in my arms, at peace and in total surrender. Looking back at this time of my life with Peter, what did I explore as his wife and caregiver, walking the whole road with him? Here's what I would like to share with you. Next generation care. 1. Use both the force of patients, caregivers, and professionals. Do not see patients only as research material, trial participants, or even helpless patients, but unite both professional and patient knowledge. 2. Start in co-participation an international brain tumor platform. Collect and unite both knowledge and material. 20 years after I met a group of Sigurd Leenstra at the AMC, you learned a lot more of the DNA and molecular biology of GBM. You discovered mutations, overexpression, transcription faults in GBM, and you uncovered the heterogeneity of this tumor. Hence, this tumor will not easily be destroyed by a one-way therapy. 3rd, build in co-participation an innovative reward system that inspires cooperation of international research groups, patients included. In the Netherlands, we have a research reward system which gives no possible incentives at all to scientific researchers to work together and cooperate together. Get rid of it. 4th, innovate in cooperation the GBM care into next generation care, in which both medical technical and psychological social aspects are united. What is for the patient and his family the balance between quantity and quality of life? Maybe the doctor has to remain a doctor at the bedside and in the outdoor clinic, and the researcher has to stay in the laboratory. Cure without care is careless. 5th, act as an excellent multidisciplinary team of doctors and nurses, which cooperate with their patients and their caregivers in all phases of the disease. An excellent team of both doctors and nurses is needed in the care of GBM patients. Nurses and nurse specialists have to be brilliantly equipped with actual and specialized knowledge, skills and competences in order to care, and make work of supportive care for the family in the palliative and terminal phase of illness. Thank you very much for listening. And let's make together work of next generation care.